Good afternoon and welcome to the continuing education course hosted today by Teresa Duncan and sponsored by Darby Dental and CareStack, today's insurance coordinator. Thank you for joining us. It's 1 p.m. Eastern, 12 Central. Again, the topic is today's insurance coordinator, the presenter Teresa Duncan. We're going to give it some time. It looks like we have a lot of folks still joining us and coming into the webinar from the waiting area queue. So we'll give everybody a couple of moments here to get settled, and we'll pass it over to Teresa so she can get started. I know this is an exciting topic. We had a lot of people register and are excited to hear more about today's insurance coordinator.
All right, let's get started. I put a welcome message in the chat to all of my fellow insurance geeks. And I know I hit some nerves because I got a lot of messages right back. And my insurance geeks, Dan, are definitely going to stick around to the end because if anything, we like to see how others are doing it. That's kind of what we live for, you know, to learn and find out how others are doing the job that can sometimes be a little bit frustrating. So let's go ahead and get into it because I want to make sure that even though this is more of what I would consider to be a foundational type of course, there's a lot that changes every year. And so foundational really is not even, it's just every year it's a new foundational course. I always want you to know what's going on in the industry. So I'm always going to give you an overview of what it's like out there. And then I'm going to, I believe Dan has a link that he'll share in the chat where you can download a copy of the insurance guide that I created this course from. So please feel free to use it, fill it out, use it as a guide. For my managers who have been doing this a long time, use it to train your people and add to it if you need to. I mean, my goodness, what I think is appropriate, maybe just the tip of the iceberg for your office. So please add to it, use it as a template. Right now, what we're seeing in our industry is there's an awful lot of networks that we have to pay attention to. There's an awful lot of contracts floating around out there. And the latest stat that we're seeing now is 28.3 is the average number of networks per provider, which honestly, it sounds like so much, but I think many of you are like, yeah, you know, because we don't even know who we're networked with because the umbrella networks, the ones that are leasing your names out, it changes all of the time. I wanted to just give you a behind the scenes on that because this is a question that I get all the time is how am I supposed to keep up with it? Well, I have to tell you that it's kind of confusing on both sides. What we're seeing on the carrier side, and I do work with carriers, part of one of my memberships is with the National Association of Dental Plans, and I have a lot of friends that work in insurance companies. So I'm not here to bash them. I see their side of it. I definitely see our side of it. I love our side, but I do see their side. What happens on their side is they're just as short-staffed and it can get just as confusing. So a lot of the networks are not being updated, meaning maybe there's an arrangement between Acme and Acme Dental and Gamma Dental. And what happens is they make this arrangement, but it takes a month for the networks to get updated. And in the past, there wasn't necessarily a rule or regulation to let you know about that. You kind of just found out about it. Thankfully, many states have passed laws where they have to let you know at least within a month that you've been leased out to a different network. I do think just watching the legislative landscape that's going to be changing too. And you're going to see that it's going to be a lot easier to find out who you're in network with. Now, what I want you to keep in mind is that if you sign up directly with an insurance company, that doesn't necessarily mean that you won't get leased out. Insurance companies, you know, a good example is United Concordia. They did not have a network they leased 2 years ago, and now they do. And that's why you're now leased out to a couple different names. So networking is confusing on its own, and I'm not going to go into it because I really try not to make that a focus of all of my talks because it's so specific to the region and so specific to your situation. I want you to find somebody who's good in your area in order to find out which networks are good to be on. But that 28.3 number, think about it. So if you're a doctor or a manager and you're wondering what the heck are they doing up there? Why is it so confusing? It's because we're trying so hard to keep track of all of this. And you need a good system to do that. Excel spreadsheets, making sure the data is correct in your computer so you have the right fee schedules. This in itself, if you're in network with a lot of plans, I think there needs to be honestly a realization that this could really turn the insurance coordinator position into a real full-time job, along with everything else that we're going to go into. Managing networks is, it's not for the faint-hearted. And so if you're brand new to dentistry, I don't want to scare you off. You will have to do this, but let's do some baby steps. Let's get into what else you have to do, because the participation piece needs a lot of concentration, but the rest of it that we're going to talk about is like your daily and weekly, and let's get into that. So I also want you to know always what's going on in the industry. Well, we have a lot more people that are covered by plans than ever before. We did have some drop off. In fact, I haven't been able to incorporate it into today's presentation because I just got a report this morning that about 46% of a certain respondents survey said that they had patients saying that they had lost their dental benefits. So you have a lot of people that have lost benefits because, as you know, there's unemployment issues all over. And I know some of you are like, yeah, I know, I can't find anybody. I know, I'm hearing it too. I get calls all the time. Do you know anybody that's good? And it's so hard out there. I think there's unicorns walking amongst us, but I don't know where they are. We need to find them. All right. So you have a lot of people that do have benefits. And what that really means for you, dental offices, is that you have a lot of people who want to come to your office to use those benefits. So to me, that's a good thing. It's just a matter of making sure that that is a good business model for you. Okay, so this is the guide that I wrote. Some of you have it already. I know I recognized a lot of names and you're on my newsletter list, so you probably already have this, but if you're not, then feel free to click that link that Dan will put in there at some point. And also the handout is going to have this clickable as well. So I want you to have it, and I want you to hopefully be able to put it into practice in your office. Okay.
Teresa, can I jump in just for one moment? Because I'm
Sure,
sure
yeah.
we're going to get some questions, which we did to get one about the handout. How do you want to field the questions as they come in through chat or Q&A? What works best for you, so I can make sure
Oh, let's
if it's
do it at the
relevant?
end. Yeah,
You
let's
want
do
to
it at
keep
the
it to
end.
the end?
Yeah,
Okay,
because I
perfect.
might cover it, and you know me, Dan, I'll go down a rabbit hole
Okay,
if you get me distracted. So
perfect. I just want to make sure we're reserving those to the end, and everybody kind of knows. Put them in there, and we'll address them towards the end.
Well, got it. Okay.
All right, thanks.
So yeah. So today's insurance coordinator, I mean, look at that. That's us, right? Complete with that face. Like, what are we doing here? Nobody told us it was going to be like that. This is one of my favorite images, and you'll see it. If you come see me in classes, you're going to see it a lot. All right. And this one here, this little girl, that's a baby insurance coordinator. She thinks she's going to have fun on that computer, but it's going to be one of those days for her. We just know it. We just have to, make it as easy as possible. Here is the thing. You have a lot of duties as an insurance coordinator. You have daily duties, weekly duties, monthly duties, and then you have strategy, which is your insurance participation and taking a look at that. Now, daily. So of course, you have to have a system for checking your eligibility and benefits. Now, I am not of the opinion that you should be checking benefits on every patient every day. It's really a lot of time. And if you're not getting it through your software, you're probably paying for it. And if you're using a service, and those can cost per benefit pull. And if you have somebody coming in and they had their cleaning at the beginning of the year, you did a benefit pull at that point, and all they're coming back for is another cleaning, there's no reason to pay for another benefit pull. I mean, if it's part of your software, that's great, but there's no reason to pay for another pull if they have the same insurance and nothing has changed. So here's my comfort level. I like to make sure that I have eligibility on everybody that comes in. Now, I would love to have it through the computer. So electronic wise, I don't want you sitting on the phone. I don't want you sitting on the phone and punching in those numbers just to see if they have coverage. Utilize the electronics that are available to you through your software, through your portals. Use the shortcuts that you have there. If you're on the phone, it's probably because you can't get a complete enough breakdown for a specific procedure. That's okay, but that shouldn't be the norm. So I want to cut that down for you. If a patient tells you they changed jobs and insurance, then definitely we need to get benefits. And at the beginning of the year, I'm always checking eligibility and benefits, because patients don't even know when they change eligibility and benefits. So I need to make sure that I remind them. What also you can do is, when you're making that appointment for the beginning of the year, or if they give you a new work number, that's always a clue for you as well. If they say, hey, I got a new work number, a new email, you want to ask, did your benefits change? what I would love for you to start doing is, if you have them on the phone and you have enough time to do this, of course, I know some of you are short staffed, if you can ask them to send you a copy of their benefits, that would be ideal. I'm not saying you don't pull them, but here's the thing. Most of the portals that these patients have for their employers, all of their benefits are online. They're all in PDF form. I think even most of the insurance companies don't even issue physical cards anymore. It's all digital cards. So they could actually go in, download their information, and send it to you. What I'm looking for, not necessarily the card, because, typically you don't find that people are lying. I mean, maybe a little bit, but for the most part, what I'm looking for is the eligibility booklet, because all of the clauses that they're subject to, I can look at it and I can see right there in their own booklet that they provided to me, what is a waiting period, what, are crowns covered, are they not covered? And many times, if you start asking for it, patients don't realize how easy it is for them to send it to you. So I would love for you to start doing that and start making kind of your own database. Also, as a brand new insurance coordinator, when you read these benefit booklets, it will tell you what the patient's seeing as far as how their benefits are explained. It helps you to explain it to them better. They're not as in-depth as our provider processing manuals that we have on our provider portals, but when you take a look at how their benefits are presented to them, it helps you to break it down to them even better. So I really like getting a copy of that. When your radar goes off, this is really important. If you're new to dentistry, your radar hasn't been honed yet, but you will get a radar, and it'll be for people who don't pay their bills, and it'll be for people who are just a pain in the butt to work with. So listen to your radar when it goes off, when it comes to insurance, or you're just not sure about their finances. I have learned to trust mine, and it's usually right now, it's not wrong. Now, why am I having you check for benefits? As I guess, as religiously as I would like you to do. Oh, let me back up. I'm sorry. Eligibility, my set is about 2 days prior for eligibility. That's the minimum. I know some offices are at a week before, 2 weeks before. If your schedule is set, especially for hygiene, I'm comfortable with that too, but you have to make sure to catch it, that if the schedule has changed, that doesn't get lost somehow. And again, electronically is the best way to do it. I believe Nicole and Dan are going to go through that at the end, and you want to see how other systems are doing it, or how CareStack system does it, so that you can see if it's going to work for you as well. So when you take a look at all these benefit booklets, what you will find is that the clauses are changing. So I, for fun, read a lot of these, excuse me. And I know I get a lot of flack for it from my friends. They're like, "You're so boring, Teresa." I know, but this is what I love. And I like to spot these different clauses and bring them to your attention. My newsletter went out earlier this week, and I already heard back from a bunch of people that were saying, "Okay, I've never seen this, but have you seen this?" And so that's how I keep people apprised of what's going on out there. Now, look at this. These clauses mean that you have to actually go into your system and set it up so that you can catch it. For example, let's take a look at the replacement of the missing tooth here. This is the third bullet point here. 24 months of enrollment, 30%. Now, 25 months and beyond, the plan pays at 60%. So what does that tell you? That tells you that this person has a plan that has what we call steps to it. So you will have to maybe create a plan for Acme employees year 1, Acme employees year 2. And that's how you would have to track that. So that gives you an idea that, yeah, the group number looks the same. And that's the key. The group number is the same, but the benefits change as the plan goes on and as the patient ages with that plan. So that's kind of a key there for you. Same thing for these periapical radiographics, the x-rays. What's happening is we used to be able to send in periapicals pretty easily and not get questioned on them. I mean, they were just easily what we call auto adjudicated, meaning it was paid without anybody really looking at it. Well, unfortunately, it became it's really highly used, and sometimes not appropriately. And so now you're starting to see a lot of clampdowns on the PAs, and even frequency limitations for them within a calendar year. You also are starting to see a lot of deductibles applying to radiographs and intraoral images. And what that means is you're going to have to change up that preventive category, because the preventive category, you're used to it paying 100%, but now you have to carve out all of these codes. So I can tell you that the clauses are changing and they're becoming more specific. And so if you have a plan that's just a straight 180/50 with none of this weirdness in it, you're lucky, because most of the time, and these are the big carriers, the Deltas, the Cignas, this Blue Cross Delta and a Cigna plan is all represented here. They're all changing and having these really weird different clauses. The goal of it, so you know the behind the scenes, is it saves the employer money to have a plan that pays more. And the longer the patient is employed by the plan, that saves the plan money. So we have to pay attention to that. I also need you to take a look at the documentation, because as an insurance coordinator, you are probably in charge of filing the claims and all of the documentation that goes along with it. So you should know that in 2018, Delta of Massachusetts said, hey, no more narratives. We just want screenshots. And that was put in the provider processing manual. It's being strictly enforced now. In 2022, you're going to see it really get enforced. It's a Delta Dental national policy now. That was new in 2020. And from talking with other carriers, they're also moving to that. What does that mean? As an insurance coordinator, I'm thrilled. I don't have to write any more narratives and then have my doctor check it and all of that. I am now going to have my doctor make beautiful notes, and then I'm going to screenshot those notes. So some of you are going, wait, no, that's not how it works in my office. I know, but you know what? Documentation is going to drive your revenue. That's my motto. I've been saying that for a long time. Documentation drives your revenue. If you want to get paid, you have to have good documentation, and not only to get paid by the insurance companies. To be quite honest with you, when I talk about documentation in classes, I'm not worried about the carriers. I'm worried about your dental board. I'm worried about the malpractice carriers. So I want you to really shape up your documentation and see if you can make it better. Templates are great, but I need you to be as complete as possible. Good clues for this are in the provider processing manual. You can take a look at that and see what their criteria are for crowns, bridges, fillings, and then you can see, do your template, not templates, do your clinical notes. If you were to take a look at that, would they match up to the criteria? So whether you're in network, out of network, your clinical notes should be really good, because it doesn't matter what network you're in if you're in front of a jury. And unfortunately, I've been involved in cases like that, and they're not pretty. So I would never want any of you to have to deal with that. So please start working on your documentation. Okay, daily checkoffs. So again, gathering the documentation. I really would love for you to submit your claims every day. This is honestly something that if you're in a super busy office and you are short-staffed, I know there's only so many hours in a day and I don't want you to burn out. But when you submit your claims, that's how you get the money going. And there's a suspicion, it's been around for a while, that in November, December, claims payments slow down. I don't want to comment on whether or not that's true. I don't know for sure, but it's talked about in all my classes. Is it true that they slow things down? I don't know, but you know what? If everybody across the country is asking me, I wonder what's going on there. So if you don't send in the claims and then things slow down, we need cash flow. If anything, COVID showed us that cash flow is necessary. We need to make sure our accounts receivables are really healthy so that we don't have all this money sitting out there. So submit your claims as fast as you can, because that means that the payment comes in. You need to have the documentation to make that work. Every day when you submit your claims, one of the reports that you get back from the clearinghouse is called a claim submission report. If you are missing information, if your claim is rejected, and sometimes requests for documentation come along with that, they will tell you in that transmission. But if you're not checking that transmission, then you're waiting, or that report, you're waiting then for them to send you an EOB requesting that information. I would rather know that that claim has been rejected that day. So I'm always going to check my transmission reports. Usually once a day is when the big chunk of them come through with all of the requests and the denials. Now, I do want you to submit your claims every day, because I want you to be able to bill your patients right away. I'm a big fan of sending statements on a daily basis. And I know this isn't a collections or a revenue cycle management course, but you have the ability now to send statements to everybody as soon as the insurance check comes in and there's a remainder. I am a big fan of text to pay, and I'm not a fan of being subject to text to pay. My vet showed me that over the weekend. They basically said, hey, here's a link to pay your bill and then you can come get your dog. That's not cool. I mean, we're not holding people's teeth at the desk or anything, but I guess it's okay on the vet side. But text to pay is great when I'm the one sending the text or you're the one sending the text, and you want the ability to do that. And I believe Nicole is going to walk through that, or at least give you a screenshot of that so you can see what it looks like. I can tell you the people that are using text to pay are raving about it, and I see it myself when working with offices. The amount of payment coming in from text to pay is huge. All right, other daily tasks. So, I mean, you guys can see this, right? It's a full-time job for one person, really. So you got to visit your carrier portals. You got to find out where your EOBs are. If you've signed up for electronic EFTs and ERAs, ERAs are your electronic remittance advice, and that's your EOBs, but online. And EFTs is them sending you the money, depositing it straight into your account. However, you have to reconcile all of that so that you can know what actually went into your bank account and close out all of the claims. So here's the thing that I want you to think about. And this is more for my managers and my doctors who are having staffing considerations and really taking a good look at this job description. Used to not be that big of a deal. When you are talking about a pretty busy office, just entering in all of those payments can sometimes take one full day and many more days if it's, pretty high volume. So this is what I'm hearing from many insurance coordinators. I am having a hard time keeping up with payments because now they're dealing with insurance checks coming by mail. They're dealing with the portals that they have to go to. Many of your insurance companies, you probably notice, are getting way more aggressive with sending you virtual credit cards. And for those of you who have decided to not accept virtual credit cards for payments, because there's an extra charge, right? You had to pay a surcharge to run it through your credit card processing. You have to go and let them know either on the website or call them, and that's even more time. So the whole payment side of entering in the insurance checks and making sure that the fee schedules are correct and everything, that in and of itself could be a real full-time job if you're a busy enough office. So please keep that in mind, because it's not just sitting and entering checks and it's easy and you walk by and they've got their headphones on. It's a good job. It can be very, very time consuming because you really have to make sure all of the numbers match. Now, the EFT piece of it has really added to the complexity. I love them. I think they're great. I love having money in the bank immediately. Don't get me wrong. However, it really takes a little bit to get used to how to read the bank statements and the transaction numbers, because not all insurance companies are the same. So you have to see how MetLife identifies their payments, how Cigna identifies their payments. And then you have to get the hang of logging into each portal to reconcile all of that. There is not one portal to rule them all. I would love it, but it's just not there. So when we get that, it would be better. I just don't know how reasonable that is because there's so many players involved. And even on the payment payer side, there's more than one player involved there. So I just don't know if you're going to get some uniformity there. Maybe, but we'll see. Okay, so daily checkoffs. So you've got the payment part, right? Now, as needed, when you're entering in the payments, what happens if you see a massive screw up on the EOB? Well, now we have to appeal. So you have to keep your eyes open for that. Now, beware, because your pile of claims to appeal can grow because you've got so many other things to do. So a good insurance coordinator is going to make sure that their appeals are sent out at least once a week. I know that sounds like it's a long stretch of time, but if you've got the volume, you probably are going to sit down at one time and make sure all of them are taken care of. If you can do it as you go, that's awesome. But what I notice the most is that people are putting them all together and then doing maybe a half a day and working on all of the appeals. Sometimes you have to go back and get additional notes. You have to talk to the doctors, hygienists, maybe they're not on staff. So don't beat yourself up if you can't get those out the same day. Just get them out as fast as possible, because there's usually time limits that go along with that. Now, I also want you to keep an eye out for these treatment plans, because what happens is, and I like to do this as part of my, let me back up. I really am a fan of having at least a daily huddle, maybe a morning huddle, whatever, but a daily huddle where I, as the insurance coordinator, am reporting in of any issues that I think we're going to have with coverage, or maybe there's a person that we need to talk to about a pre-authorization, whatever the reason is. If a patient has changed insurance, you need to make sure you go in and update that person's fee schedule, because their fees might be better and you want to make sure you're being able to take advantage of that. Also, if the person doesn't have insurance anymore, or they switch to an out-of-network insurance, which is, great, then you can charge your regular fee. You want to make sure that that's updated. The worst feeling in the world is when you submit or give them a treatment plan, you print it out and it's got your Delta fees, and the patient's like, oh, well, I don't have Delta anymore. I thought I told you that up front. And you're like, oh, okay, well, hold on a second. Come back with a much bigger treatment plan. That's a very hard conversation to have. So we want to make sure we head that off at the pass. Now, the other piece of this is knowing that if you have a denial versus a disallow, there's a couple extra steps involved with that. And this is if you're in network. Denials, you are going to, of course, appeal, and you're going to try your hardest to get it paid. So many times you can get your appeals paid. I do think some of these denials are definitely automatic, and so you can go ahead and at least bring their attention to it. Disallow is a little bit more difficult. Disallow means that not only are they not paying for it, but you also have to write it off, because according to your PPO contract, you're not even allowed to charge that fee. So there's a lot that goes into that. And there's definitely, I spend a good half hour on this in my other classes, but I do appeal, because there are times when I know my provider spent a lot of time on it. So I do appeal. I ask for alternate benefits. Maybe there's another code. I don't change the code. I'm going to be real clear about that. I don't change the code because that's fraud. I'm going to stick with what we did, but I'm going to say, hey, if that gingivectomy wasn't allowed, is there another alternate benefit that we could apply? And, then that's a whole thing of going through the motions with the rep. Now, the other part of that is the patient will get that EOB that says it's disallowed and that there's a patient portion of 0. And so you have to make sure you let the patient know, if you're appealing it, that I believe this was a mistake, Mrs. Smith. We're going to be appealing it. I know it looks like there's no fee for you, but I think they processed it wrong. So just want to give you a heads up. If you get something back in the mail, it's not a mistake. We believe that it was processed incorrectly in the beginning. So my big thing is, I know patients don't like surprises, and I think all of us would leave any doctor's office or any retail store if they switch the prices up on us. And although that's not what we did, that's what they're going to perceive. And so I want to get ahead of that and give them a warning. All right, this insurance aging report. Well, when the lockdown happened, I was very surprised. I was kept busy by a lot of offices who had time now to run their insurance aging report, and they realized how many claims were outstanding. And honestly, it was because we were busy. And the insurance aging report takes time. So again, you can see why this is a full-time position, the insurance coordinator. Many offices I know have at least 2 insurance coordinators if they've got about 3 or 4 doctors and they're in network. So this can really take up a lot of time. So if you have walked into a situation where you're cleaning up someone else's mess, and we've all done it, some of you already had someone's face pop into your head. I know I sure have a couple faces that pop in. If you're cleaning up someone else's mess, you're going to have to run this report at least every week until you can get things cleaned up, meaning you have refiled, meaning you have notes so that you can follow up. You've made contact. You have found the ones that are high dollar amounts because they're probably requesting information. You have taken care of the ones that are oldest because there's typically timely filing deadlines involved. So I'm going to really work on those 2 sets. I'm going to take care of the ones with the biggest dollar amount, and I'm going to take care of the ones that are outstanding, have been outstanding the longest. So I'm going to work on that. And honestly, if you're coming into a cleanup situation, you got to work this every week at a minimum. Some of you are working it every day because of the volume. I was talking to one office and they ran the report, and it was close to $100,000 in outstanding claims, and they just had no idea that it was running at that level. I know some of you were like, wait, were they making any money? Yes, and that's the problem. They were making money, so they really didn't pay attention to it. They didn't realize how much of a difference it was. So they're pretty happy now. During the maintenance stage, meaning that you've got it to a level, you're happy with it. Every 2 to 3 weeks I wouldn't go further than 3 weeks. I'm an every 2 weeks type person. I'm actually just kind of paranoid like that. I have to run the report and make sure everything is okay. At the longest I would go is a month if you're not super busy. But if you have high volume and if you're in network with plans that you're just not sure of, maybe you're newer to the job, I would definitely make a point of running it more often. It's not going to hurt. if you're keeping notes to yourself and you're knowing, how long ago was this filed, you can quickly read that report and see which ones need to be addressed. And so don't be afraid of running it every 2 weeks. I really don't think it can hurt. So if you're in that situation where you're cleaning up, I get it, I understand, and virtual, fist bump to you, because it's not easy to clean up someone's mess. People sometimes don't know just how bad of a deal they're giving us, right? All right, now yearly. So this is where we're going to zoom out a little bit. We're going to go more high level here. So for those of you that are in network, one of the things that kept me really busy the past, since the lockdown, has been these consultations. You can book a consultation call with me for an hour and you can talk about whatever you want to. But most of the time it was about network participation. And it was offices saying, I don't think I'm making money. I've been meaning to get off of this plan. Can you help me take a look at it? Should I, shouldn't I? One of the biggest, there are two things that came out of those. The big overarching feeling was, I know I'm losing money. Now I didn't realize how much money I was losing. So if your crown fee is low and you've known it for a while, when you really take a look at how much it is, then it can be really shocking. One thing that's factored into these conversations is that the overhead has gone up. So many of you lost people, many of you are hiring people at salaries that are really just out of control. Maybe that's the new normal for us as far as salaries go, but it's really a shock for some of us that have been, around a long time, and we're not used to paying those numbers for certain staff. And, the ones that are coming in, maybe they're deserved, but it's still a shock to your overhead. And if you're taking a look at your profit and loss and really planning out, what percentage of your overhead is salaries, many of you are finding that has been blown out of the water this year because of staffing issues. So you probably have noticed that in addition to that and your rising costs, if you're working with a company that helps you keep your costs down, wink, wink, that you've got one on the line that does a good job of that, but PPE costs have gone up. I mean, you all know that. So when you factor all of this in, are you still making the margins that you thought you were making? And that really has been a big feeling that I've been getting. The second is when they do decide, or if they do decide to get out of network, I need to have something to capture the ones that don't have steady insurance, the ones that are working part-time, the gig workers, and then there's the senior citizens. So it's no surprise that membership plans have come out of nowhere. I mean, they've been around, but now they've really exploded in popularity. So I'm not surprised to get that question almost always when I have classes and webinars. So when you want to take a look at your participation situation, and this is in the book too, so you feel free to just kind of sit back and listen to this. I want you to take a look at what the number of covered patients are per plan, because that's really how you decide whether or not that's working for you. You take a look at the referral sources. I want you to have a referral source for MetLife, for Cigna, for Delta, whichever ones you participate with, because at the end of the year, when I run my referral report, if most of your referrals are coming from an insurance company, I worry, because maybe you don't have a lot of patients that are referring patients to you, and you need that. You need another referral source other than just straight insurance companies. I also want you to take a look at your biggest write-off. So let's talk about, let's say Nationwide, because I don't think they're a dental provider, but let's say Nationwide Insurance. You have a contract with them. It's not a great contract. The ones that do come in, they're not wonderful, whatever. Then you take a look at the referral report and you realize Nationwide has not sent you one patient in all the time you've been contracted. So here's where I need you to understand the business side of what we're doing. The reason that you lower your fees, so this is the only reason you agree to lower your fees for the insurance companies, is because they have agreed to send you patients. So that's the handshake there. That's the agreement. It's a contract, and it's something called consideration, where one side gives up something, the other side gives up something. You're giving up fees, the insurance company is giving you patients. So that's considered marketing, really, if you think about it. Now, if you're lowering your fees, and you're not getting anyone, what are you doing? So you have to think about it. Why do I worry about that? You're thinking, well, if no one comes, then what's the big deal? So it's what I would consider to be a liability. So say Nationwide realizes, okay, we need to up our game here. What if we lease out our network to Cigna, MetLife, whatever? Well, here you are with a contract with pretty low fees. You may get other insurance companies coming in and utilizing that fee schedule. So it's a liability. It's an unrealized liability, right? So you have to really look at what's out there and what's on your books. I also want you to take a look at how many times you've had to write off additionally in addition to your fee schedule. So let me explain this. When you have adjustments, right? So you do write-offs. I would love for you to have a write-off for each insurance company. So MetLife has one, Cigna has one, Delta has one. This is not the difference between your fees. That's different. So your fee schedules, you're going to be using fee schedules in the computer, submitting full fee on your claim forms. That's pretty standard. This write-off is when you are trying to get something appealed and you just can't make it work, right? So you end up having to write off the amount. It's a disallowed and you end up having to write it off. This is what I'm talking about. So when you run your adjustments at the end of the year and you realize, oh my gosh, Nationwide, I ended up writing off like 55,000 to Nationwide because of, they don't let me charge for gingivectomy. They don't let me charge for crown lengthening, all of the stuff that you have to write off. That's in addition to the difference in fee schedule. So when you really take a look at everything, it may not be working for you. Now, the other side of that is maybe you're in a situation where you think participation works for you. Maybe you're a new office and you do need to get people in. That's okay. Different business models, right? So I'm not saying don't participate, just make sure it's working for you. And the carriers would even tell you that. The carriers have said to me, doctors, if it's not working for them, they should get out. It's business to them and it should be business to us. So when you take a look at these numbers, these reports here, what you'll do is get a really good idea of what your participation levels are. I'm just going to go out and say it, that if you run these reports for the first time, you're actually going to be finally paying attention to it, which is going to make you, in the back of your mind, you're going to be paying attention to it more often. The write-offs that you make, you're going to start thinking about them more often. It'll start clicking to you which insurance companies are making you appeal the most, which insurance companies send you the worst quality patients. Let's be honest, there's usually one job or one employer in the area, and everybody they send to you, you're like, oh, it's another one of those. And they're kind of a pain. So maybe you factor that into it. You take a look at your top 20 to 30 procedures and see how far off you are from their fee schedule. If it's a 40% difference, a 40% write-off, and your overhead is at about 55, 60%, you're not really clearing what you think you are. So it's really a good idea to track this. If you're not ready to make any changes, that's fine, but at least track it so that you have a year, 2 years of history so that you can make really good decisions when that happens. I know many dentists are actually good at pulling the trigger and doing that, but I'm a little nervous with that. At a minimum, I would look at these 3 reports to decide what to do there. I can't make emotional decisions like that. I get really nervous. I need to have my numbers and my facts and everything all ready to go. All right, so this is what I hear all the time. I hear that you're behind because the insurance process is really getting away from you. So tackle your staffing needs first. You know what? I would rather you hire a really good receptionist, treatment coordinator, financial coordinator, and the insurance coordinating piece can be temporarily outsourced. But I want you to also take a look, though, at what the capabilities are that you may not be using in your software, because I will run into people that say, I need to outsource everything. Believe me, I'm a fan of outsourcing. I know some companies that do a real kick butt job with it. They're great at it. I also know a lot of companies that do a miserable job too. So you really have to vet them. But most software you will find has that already built in, meaning the aging report can be set up to be run on a regular basis. You can set up your eligibility and benefits checks to be done on a regular basis so you don't even think about it. But I would make sure that you have all that set and then take a look at your outsourcing. First things first, if you're a small office, I would absolutely outsource your payroll. That could be outsourced big time. And you know what else I would outsource? I would consider outsourcing my phone calls to patients, my treatment plan follow-ups. Why? And people are like, well, no, I can't do that. That's a great part of the job. I'm so good at it. I know you're good at it. I know you are. However, I also know some of the offices or the companies that offer this are fantastic at it, and they have time. They have an uninterrupted, time that they can call the patients and contact the patients, follow up with email, text, whatever, and you will tell them exactly what needs to happen. Once you get that set up, doing follow-up for treatment plans can be taken off of your plate. And quite honestly, that's going to net you more than outsourcing your eligibility and benefits checks, because that's going to have some return. And so that's something new that I'm really talking about in the last year, because I've seen what a difference it makes. There's been some real changes in attitudes around doctors outsourcing more things. And so it's been great to see the changes that these companies have made to stretch with that. So again, I would make sure that you clean up everything that you can and get that set up. There are companies that will do that temporarily. They just will come in, clean up, and get out. They don't want to work with you long term. That's awesome. But above all, please remember to leave yourself notes, because you are only one person, or maybe one of a two-person team that does insurance, and you need to be able to pick up where the other one left off. So documentation is not just for the clinical team. Documentation, my insurance coordinators, my insurance geeks, documentation applies to us too. We need to mark down who we talk to, what the reference number of the call is that we're on, and not just say to ourselves, oh, I'll remember that. I'm not going to write that down right now. I'm too busy. I'll remember that, because those are famous last words. And let me tell you, I've been doing this a long time. I don't remember anything. So I don't even try it anymore. The new thing that you're seeing, I just want to make sure that you're aware of this, and it's kind of come out of nowhere. And that's why I have this picture. They've been around, but for some reason, well, I know it's not for some reason, 2021, you all saw a lot more Medicare Advantage plans. And the perception is, well, I don't want to participate with Medicare. Well, that's fine. You don't have to, but you're still going to get Medicare Advantage plans, and you have to decide what your level of what we call enrollment is. I am not a Medicare Advantage expert, so I'll give you a resource in just a second. Why it's confusing for us is because they're administered by dental carriers, Humana, Cigna, Delta. So you'll see something at the top that says MA or Advantage or Medicare Advantage plan. And that means there are some slightly different rules that apply, and you do have to know the difference in them. So the good news is some of these plans are great because they don't cover as much. And so maybe some of the big ticket items, you really don't have to worry about it being part of insurance. At least their preventive gets cared for, which is great, but not all plans are created equal. For example, one Humana Advantage plan that I ran into, it's $1,000 yearly benefit, but it's $250 per quarter. So, good luck explaining that one. So I do have a podcast where I interviewed Delane Glogie, she's my Medicare Advantage, along with Christine Taxon. She's my Medicare Advantage expert. And I did a whole episode where I had her teach it to me. And that's why I'm linking it for you guys, because she taught me, and I still need to look at my notes. So I think she can teach you too. So feel free to check that out. Part of being a good insurance administrator, insurance coordinator, is having resources and not thinking that you know it all. That's my biggest tip off. I'll tell doctors all the time, if you have an insurance person that's working for you and they say, oh, I don't need to take a class, I've been doing this for 20 years, beware, huge red flags, because I've been doing this for almost 30 years. Oh my goodness. I've been doing this for almost 30 years and I have to keep up with it. It changes every year. And then even more specifically, every quarter, sometimes with, how they write their plans and structure their plans. So we all know about Coding with Confidence. It's a great resource. And Fair Health Consumer, I have that down because that is a website you can go to and plug in your zip code and the procedure code, and it gives you an idea of whether or not you're competitive in the area. My book is called Moving Your Patients to Yes, and that's my physical book, not the ebook that you'll get. It's all about insurance conversations, how to talk to your patients about insurance. That's on my website. I do love the CDT Coding Companion Guide. Now, you can get the bundle. It comes with an app, and I can't believe I'm excited about an ADA CDT app, but there it is. The Coding Companion every year gets better and better because every year they keep adding scenarios. It's actually a pretty thick book now. And so why I like it is because every author for every category is tasked with coming up with all these different scenarios and making sure that they're all current. So you could open that up and probably find every scenario that you're looking for. I actually use it to teach from when I'm working with teams. So highly, highly recommend it. And again, there's my podcast. I have another one called Chew on This, where it's more of the lighter side of dentistry. So if you like laughing at silly stuff in dentistry, you should check that one out. My Nobody Told Me That is more management and dental insurance information. That's for my hardcores. And I hope that you're checking both of those out. Here's my resources for medical billing, because I get this question all the time. Do you teach medical billing? I don't. You don't want me to, I'm not even going to offer. I'm terrible at it. So here are the people who are good at it. So you can, this list is going to be clickable for you. The one at the top is, they have actually a certification for dental medical coding. She got certified through an actual accredited organization. And so that's, as far as I know, the only dental to medical certification that's out there. And so maybe that's something that you want to do. I do think we're going to more medical, dental. I think we are going to see dental get wrapped up into medical pretty soon, I think. And so if you want to position yourself for being a really good dental medical coder, that might be something you look into. And if you really want to have 2 full days of insurance, check out the Insurance Extravaganza on November 12th through 13th down in Orlando, Florida. So, but if you're not that into insurance, don't come because you'll be miserable. It's all insurance. So check that out. And then we're going to take questions, and then definitely stick around because Nicole and Jeff, and not Jeff, Jeff is not going to do it. Nicole and Dan are going to go through some screenshots. And honestly, I always sit in as many software demos as I can because I got to keep up with what's going on. Maybe you'll learn a trick here. Here's how you connect with me: social media, my email, all of that. And I want to thank Darby and CareStack for sponsoring this. They are just really big proponents of education. So I was thrilled to get another call from them. So Dan, how are we doing with questions? What's going on there?
There's been a lot of them, Teresa. I'm going to have Nicole, because I see her going through the chat right now. I can see her scrolling through. Nicole, have you kept pretty good tabs? Do you want to grab a couple of those questions and field those?
Yeah, no, of course.
Along to Teresa.
So where can I get the criteria booklet? That's one.
The criteria, so that's probably the provider processing manual. So if you are a participating provider, log into your portal and there's a provider resources section and you can download that. Now it's going to be well over 150 pages. And what it does is it goes through every procedure code and tells you the criteria that you can use that they use in order to approve benefits. So what I do is do a compare and contrast with what I have as a template, and hopefully I have the fields in there. I'm not saying use it if it's not the case. We don't want to lie, but if you have, if you see that Delta's wanting to know how many millimeters, or they say we only pay benefits on 3 millimeters of tooth structure missing, for example, am I going to have something in my template that says how many millimeters of tooth structure missing? Yes, absolutely, because I want to make sure that that's something that they can scan easily. The consultant reviewer can scan easily and see that. So check your provider portal.
Perfect, thank you. And to Lisa, who asked if you missed the code, you have not missed the code yet. We're gonna get through some of the questions, then we'll get that over to you all of you guys.
I did have one. Oh, sorry. I was gonna say, I just saw one come in, Nicole. I was gonna grab, if you're okay with that.
Yeah, no, please do.
So Teresa, one was asking like approximately what percentage of offices do you see going to drop down here out of network?
Oh, it started off as a trickle during the lockdown. And I mean, it's kind of hard because I've talked to so many, so I'm probably skewed, but I keep in touch with a lot of consultant colleagues of mine. And it's the top question that they get. So I would say, I don't have a percentage, but I will tell you that the number getting out of network is higher now than I've ever seen. And honestly has surprised me. So I would say that's a pretty big number. Even offices that are in areas that they used to say, I can never, I've got, too many patients on here. Once they took a look at the numbers, they realized how it just wasn't working out for them. Also, there was I just talked about this in my latest newsletter. The Cigna fee schedule cut went around. It was like a 30 to 40% cut for many providers. And that hit a trigger. I don't even know if that was a logical decision. There was a lot of emotion baked into that one slew of emails that I got.
Fascinating. And Nicole, you had one too before I jumped in there.
Oh, there's a lot that are coming in.
Oh, and you know what? If I can't get to them all, if I could just get a copy of them from you all, then I can take the time and answer them tomorrow or over the weekend.
Yeah, one that we've gotten multiple times. Can you repeat the first health consumer website and what it's for and how the office will benefit to use that website?
So it's fairhealthconsumer.org, and it'll be clickable in the PDF. So fairhealthconsumer.org, what it does is it aggregates claims and how much the UCR is that are coming in on claims. And that's why it's important to always file your full fee, because they see that, and that's how they base allowable amounts. So what it'll do is you go in, put in your zip code and the procedure code, and it'll tell you what the 80th percentile is for that particular fee in your region. So you can see if you're competitive. Now, I have to be honest, I haven't checked it in about a year. The last time I checked it, they were, I think, a year behind on fee schedule data. So you just have to, raise it up a little bit. But most of the time, if it's the first time you're checking and you haven't raised fees in a while, you're going to find you're already below that number. I would raise fees every year for that reason, because cost of living, everything goes up. Your lab fee, I mean, I hate to say it, but your supply fee went up, and that all went up. So you also have to raise your fees.
No, thank you for answering that. Oh, go ahead, Jim. Go ahead, Dan.
You call me Jim. That's all right.
Yeah,
Take it. We have one from a new insurance coordinator, Teresa. They're asking, would you recommend moving your patients to yes for beginners?
Yes, because as a beginning insurance coordinator, you don't know what you're saying. I mean, I remember you don't know what you're talking about, but I'll give you one tip, because baby insurance coordinators, you guys have my heart, because the conversations are tough that you have to have with patients. And if you aren't sure of the dollar amounts, it makes you even more hesitant. So my advice to you is not only the book, not only practicing your conversations, but the better you get with insurance estimates, because you have the numbers in there, you're tracking it with the software, you've read a lot of benefit plan designs. The more you do that, the more confident you'll become. Your conversations will get better. But in the beginning, it's not uncommon to fumble a lot. I've said some really dumb stuff in my time, believe me. So it's okay. Don't beat yourself up. Just take the lesson from that and try not to do it again.
I think I read it as well too, and I don't even do insurance, just have a better understanding as I talk to folks. It's a great book.
Thank you.
We have two that kind of go hand in hand. On being out of network, approximately what percentage of offices you speak with are going out of network? And then there's another one going between multiple screens here. What do you do when an insurance company keeps pushing the doctor to be in network with certain plans and the doctor wants to be out of network?
So if the doctor wants to be out of network, I mean, just stand strong right now. If they're pushing for you to get in network, then one of two things are happening. One is that they may be losing providers in that area, and so they're realizing they don't have enough providers in a certain area, which is tough, because you want to be able to sell that you have a ton of providers available. The second is that there may be a group of employees or one employee that have been requesting that you get added to the network. So patients can actually go in and say, do you have a doctor you'd like to put in the network? And then they fill out your information. That's where you get this letter that says one of your patients has requested that you be in the network. Well, if that's the case, then yes, that's one or two people that want you in the network, but are those one or two people worth 30% of your fees? So I would stay strong. If you think it's a good idea, based on other factors, maybe you're terribly slow, maybe you bought a new practice and you're not as busy as you thought you were going to be, maybe, but as a long-term strategy, I wouldn't do it just because you keep getting letters about it.
No, thank you for taking that on. Then do you know what percentage of clients you're currently working with that are
the percentage of people I'm working with that are going out of network is probably 80% of them, because they're all called wanting to go out of network and they're wondering how to do it. So it's hard for me to give an answer that it may not be representative across the board. And that's why I said, I think the sentiment is, if you're going to get out of network, now is the time. I hear that. I see that all the time on Facebook groups.
And if anyone has any additional questions on that, please send them through the chat. You have quite a few questions on reports to run. So for example, how do I access claim submission reports, track referral sources, things like that.
So it's going to be software specific, and definitely, this software makes it easy and they can show you that. So definitely in your report suite, there's a couple different ones to run. If you download that guidebook, it'll tell you which ones to run. It doesn't tell you the keystrokes, obviously, but the referral reports, you just want from a 1 year basis, who sent you the most patients in 1 year period. I would love it to be full of patients or local businesses, but unfortunately it's going to be mostly insurance companies. And so you need to work on that to be more of internal referral or business. And then the aging report, you usually can access that from the financial dashboard on your software. And you want to set it up so, just quickly just run it over 30 days. Don't run the current ones because they're out ready to be paid. But anything over 30 days or over 60 days, just get your feet wet, just run that report. If you run a full insurance aging report, it's going to be huge because it's going to be everything. So you want to filter.
No, thank you for providing that information. And I know we're at the top of the hour, so did we want, because there are a lot of questions to get through, so we're definitely going to have to take these offline and hand them over to you, Teresa, because
I knew
about
you
20.
guys were, they're insurance geeks. I knew it.